Airway Management, Chapter 10. This is Part 4 of 4. We're going to talk about some conditions requiring oxygen. The atmospheric concentration of oxygen is 21%. 21% oxygen is not sufficient concentration for functioning in ill or injured patients. So some of the conditions that require oxygen: respiratory arrest, cardiac arrest, heart attacks, strokes, lung diseases, respiratory distress, shock, blood loss, fractures, head injuries. So there's a lot of times we give oxygen. So why give the patient oxygen? Because of hypoxia. An insufficient or deficient of oxygen in the body's tissue, we're going to give them oxygen because they're hypoxic. Some acute causes, meaning sudden, acute, meaning sudden onset. A person trapped in a fire, drug overdoses, especially narcotics because they're respiratory depressants. Heart attacks, chronic causes, COPD, chronic obstructed pulmonary disease, emphysema. Look at some of our oxygen cylinders. Portable oxygen cylinder is a seamless steel or aluminum filled cylinder filled with oxygen under 2,000 psi, pounds per square inch of pressure. No matter what size it is, the jumbo, the D cylinder, the E cylinder, they're all under 2,000 psi. D cylinders, the middle bottle, holds about 350 liters of oxygen. The E cylinder on the right-hand side holds 625 liters. So the way we can tell oxygen cylinders from, say, acetylene or other types of cylinders that have some sort of compressed air in them is for oxygen, the bottle's going to be colored green and silver, green and white. As you see, these are silver and green. There'll be a label on it that says oxygen, and it has what we call a 2,5 pin index on the valve to ensure that the proper regulator is used versus an acetylene regulator. The pins on the regulator on acetylene is different than what they are for oxygen, so we don't cross the regulators. The oxygen cylinder regulator will only fit an oxygen bottle. The acetylene regulator is only going to fit an acetylene bottle. Something to keep in mind: the safe residual pressure for an oxygen tank is 200 psi, which 200 psi is the change out time. If the regulator gauge shows 200 psi, it's time to put a new oxygen bottle in there. One of the things we don't want to do is run oxygen bottles dry, because there's a couple reasons. One of the biggest reasons is condensation that can build up in there because of the compressed air that's in there. Oxygen it's medical oxygen. It's not standard oxygen. You can't just go buy a bottle of oxygen, medical oxygen. You would have to have a doctor's prescription for it. So the key thing here to remember is 200 psi is the change out time. according to National Registry books and everything. But most of the time, out in the field, we'll change out our bottles at about 500. And 200 psi is the minimum pressure that could be used to run the oxygen to your patient. So remember, 200 psi is the correct answer on any test. Out in the field, it's 500 psi when we change out. Here we have fixed oxygen cylinders in the ambulance, also known as onboard oxygen. They're large green bottles of oxygen. It's a large cylinder, typically an M cylinder that contains about 3,000 liters of oxygen. Once again, the safe residual pressure is 200 psi, whether it's an M cylinder, a D cylinder, 200 psi. Because below 200 psi, there's not enough oxygen in the cylinder to allow for proper delivery of oxygen to the patient. And we try, before the cylinder reaches the point of 200, to change it out at 500 psi. But for testing purposes, remember 200 psi is when we change out the oxygen. Some safety with oxygen. You're going to inspect it before use. Use proper gauges, regulators, and tubing. We want to use non-sparking wrenches. We want to make sure that the regulator seats properly to the valve and gasket or O-ring is in good condition. We're going to open the valve fully and then close it a half a turn. Some people, some guys, gals, they'll open the cylinder, a half a turn. Well, are you going to get oxygen out? Yes. But the problem is, you turn it a half a turn. What if something bumps it? Now it turns it off because it's only a half a turn. Where if you turn it open fully, you're going to have to go around 3, 4, 5 times to get it to shut down. So you take the chances of hitting it and shutting it down out of the equation. Some other safety: store the cylinders in a cool, ventilated room and make sure they're properly secured. You want to have them in a container of some sort that keeps them standing up and to keep from falling over, because if you break off that yoke of the oxygen bottle, the thing's going to take off like a missile. Need to maintain the cylinders, and they need to be hydrostatic tested every 5 years. We don't want to drop cylinders or leave them standing without having a hand on it. We don't want to smoke or use near open flame. Oxygen supports combustion. We don't want to use grease, oil, or fat-based soaps on the device that will be attached to it. We don't want to use adhesive tape over to cover the outlet to mark as a label. And don't drag or roll the cylinders on their side. Remember, cylinders are under pressure at 2,000 psi. Oxygen supports combustion. Oil and oxygen don't mix. One of the hazards of oxygen is infant eye damage. Oxygen delivered to a premature infant can cause scar tissue to form on the retina and cause blindness. So don't withhold oxygen from a premature infant, but routine administration of oxygen just because is not sufficient reason to administer it. COPDers, end-stage COPD patients stimulation to breathe is by their hypoxic drive, where they have too low of oxygen concentration. The correct theory being that you administer too much oxygen to a COPD patient, they'll stop breathing. That's not true. It is true that if you administered 15 liters of a minute of oxygen for 4 hours to a COPD patient, they very well may go into respiratory arrest. The key here is to remember, never withhold oxygen from a patient who needs it. Never withhold oxygen from a patient who needs it. Talk about administering oxygen. If the patient's not breathing, we're going to use artificial ventilation with the bag valve mask. If the patient's breathing and needs supplemental oxygen, we're going to use a non-rebreather mask, or as it's also known, NRB, non-rebreather mask, or we're going to use a nasal cannula if the patient cannot tolerate a mask. Nasal cannula, abbreviation NC, is also acceptable to the patient whose SpO2 is 100%. We're not withholding oxygen, we're still giving them oxygen, but we're giving oxygen to a patient through a nasal cannula that has 100% SpO2, saturation of oxygen all the way down to the fingertips or the toes. Of 100%, we're going to give them 2 liters a minute via nasal cannula. Once again, never withhold oxygen. Nobody's ever been charged with treating the patient with oxygen. They've been charged for not giving oxygen to a patient when needed. As we've discussed earlier, after discovering an apneic patient, non-breathing patient, immediately begin bagging the patient to and apply room air, which is 21%, and then we're going to apply supplemental oxygen through the bag valve mask. We're going to start with the BVM just on room air at 21% oxygen, and then hook up to an oxygen source. Talk a little bit about the child's airway versus the adult airway. Remember that the mouth and nose and the trachea of infant and children are smaller and more easily obstructed. Their tongue is proportionately larger than the adult. The child's tongue is proportionately larger than the adult. And the child's windpipe are softer and more flexible. That's why we don't use a head tilt chin lift method. We want to put a rolled towel underneath the shoulders of the child, because if you notice, the child's head is more oblong than the adult head. So we have to pad underneath the shoulders versus using the head tilt chin lift method, because we do not want to collapse their trachea. With infant and children, we want to avoid excessive hyperextension of the airway. This can collapse the trachea and close off the airway. We want to avoid excessive ventilation pressures and volume. We only want to give enough to make the chest rise. Excess air, if we bag too much, will enter the stomach and cause gastric distension. Think about blowing up a balloon. You blow up a balloon, blow up a balloon, blow up a balloon, it's eventually going to burst. Well, that's the same thing with gastric distension. You start bagging the stomach with air and not getting it down into the lungs, that stomach is not going to burst and blow out through the skin, but they're going to vomit. And they don't say, hey, I feel like I'm going to get sick. They just let it loose. And now you got to suction, get all the secretions out before you can go back to ventilating your patient. Gastric distension leads to pressure being put on the lungs from the gastric area and reduces the air capacity of the lungs. And remember these differences when applying supplemental oxygen delivery devices. We have a pediatric non-rebreather and we have the adult non-rebreather. The best device to deliver a high concentration to a breathing patient is via a non-rebreather. The patient's exhaled air escapes through a valve and is not rebreathed. The nasal cannula, on the other hand, delivers low concentration of oxygen between 24 and 44%. The nasal cannula is very useful for patients who cannot tolerate a mask. We're going to use a setting between 2 and 4 liters of oxygen a minute. It can go up to 6, but the problem is 6 liters a minute through the nose, because the nasal cannula goes in the nose, will dry out the nasal passages and become very painful to the patient. So we stay between 2 and 4 liters a minute with the nasal cannula. For our COPD patients, we can use CPAP, continuous positive airway pressure. It's non-invasive ventilatory support for respiratory distress. A lot of people that have sleep apnea will wear a CPAP unit at night. And it's becoming widely used at the EMT level for treatment of congestive heart failure. The mechanism of the CPAP is that it increases pressure in the lungs, it opens collapsed alveoli, it pushes more oxygen across the alveolar membrane, it forces interstitial fluid back into the pulmonary circulation. So it's forcing everything back to where it's supposed to be. The therapy is delivered through a face mask held to the head with a strapping system. One of the things we need to watch out for and use caution is with patients with potentially low blood pressure. Some indications of use for positive pressure or airway CPAP. The indicators: the patient must be alert and able to follow commands, must have obvious signs of moderate to severe respiratory distress, the patient must be breathing rapidly, and the pulse oximetry reading must be less than 90%. Those are the indications. The contraindications meaning when we would not use it. If the patient's in respiratory arrest, the patient has a pneumothorax or any sort of chest trauma, the patient has a tracheostomy, the patient has an active GI bleed or is vomiting, or if the patient's unable to follow commands. Some complications to the CPAP is some patients may find CPAP claustrophobic. The possibility of causing a pneumothorax by forcing too much oxygen into the lungs. CPAP One of the complications is it can lower a patient's blood pressure. That's why we don't use it on somebody that already has low blood pressure. If the patient shows any signs of deterioration while using the CPAP, remove the CPAP and begin positive pressure ventilations using a bag valve mask. Talk a little bit about airway management complications in special situations. Facial injuries. There's a lot of blood vessels in the face. Can lead to a couple of problems. Severe swelling from blunt injury, bleeding into the airway. So with facial injuries, you need to be prepared to suction the airway and be prepared to insert an adjunct if needed to help with ventilating. Dental appliances. Dentures can be a source of a foreign body airway obstruction, so consider removing them in any patient who is unconscious. If you remove a patient's dentures, don't put them on the floor, because you know what happens when you put something on the floor? Somebody's going to step on them and break them. If you ever take off a patient's glasses, don't put them on the floor because somebody's going to break them. Put them up on a dresser, put them on a nightstand, hand them to a family member, but don't put anything on the floor because you don't want the stuff to get broken. So some of the dental appliances: crowns, bridges, dentures, pieces of braces. One thing about dentures is if they are well secured, they may benefit the mask seal because they provide shape and structure to the mouth. So if they are in there and secure, you can leave the dentures in there. You don't have to take them out. But if they're loose, take them out, hand them to a family member, put them on a nightstand, put them on a dresser. Just don't put them on the floor where they'll get the possibility of damage. This is the end of Chapter 10, Airway Management.